Good afternoon, everybody. It's time for the June updates. So looking forward to going over some great news for us. So of course, one of the things we had talked about in the past, right, was not having to bring back up our old debt. And we do not have to bring that back up. So that is good. But as we have retired our old debt, we still have to have the ability to match our revenue with our expenses. And we still have some opportunity in that space. There's a ton of initiatives that we have in place, and I'll give you kind of two examples. One is supply chain, and we're doing a lot of retooling in that space. And so as we look at our 2024 kind of calendar year, we had about $500,000 in expired items. And so with not managing that inventory, we had just certain supplies all over our network that actually expired. And so what that happens is we've purchased those. We can't resell them. We can't use them on patients. What we have to do is we have to throw them away. So, we'll never get to zero, but a goal for us to probably hit 20,000 of expired in a year is probably reasonable, which is of course a far shy of 500,000, which is what we had expended last year. The second thing is really about charges. And, when we think about hospitals and how we kind of manage care across our continuum, one of the things that a critical access hospital is different from a billing standpoint related to a PPS hospital, which is what we used to be. Critical access hospital, there are more things that are kind of in that bucket of things that we actually can charge for and then get reimbursed for. So certain procedures, certain chargeable items that we would not necessarily have been able to get reimbursed previously in a PPS hospital, we can in a critical access hospital. So as we move forward, there is probably a couple of $1 million, honestly, that we've kind of left on the table by us not being able to either have the right orders, the right documentation, the right capturing of the actual charges for whatever items or procedures that we have done. And so we're going to really spend a lot of time working really hard trying to redevelop our processes, make it easy for us to do the right thing and hard for us to do the wrong thing, so we can really make some significant movement in that space. That will help us mitigate some of that expense versus revenue. So we want to drive that revenue up. The other thing, honestly, is our census. We want to try to get our census up. We're working very, very hard to add medical staff. Cardiology is probably our biggest primary focus right now because it's really one of the biggest reasons why we have transfers out. And it's not interventional cardiology, it's really medical cardiology on the medical management side. And so hopefully we're going to have cardiology telemedicine hopefully in the next month or so. And so that is going to start to mitigate us losing those transfers outside of the hospital. Next thing I want to talk about is our operational KPIs. And we have three that were really kind of, focused and are kind of right at the top. One of those is, we had the swing bed and we've had a number of conversations about this. One of our first issues or opportunities, let's put it that way, was that when we had our patients, we were not evaluating those patients. Did they meet criteria potentially to go into our swing beds? That was happening on about day 7. We have fixed that process. The case management team has done a fantastic job. And now we're at less than 2 days on average. We are assessing every single patient to see if they're going to potentially meet swing bed status. So they're blowing that out of the water. What we need next is actually more volume. And so as I had kind of mentioned a little bit before, on our own admissions, we will have a real difficult time for us to get to an average of 5 swing bed patients per day for a census of that. And so we're going to have to really start to market to our sister facilities around our service area who do not offer that service letting them know and making it easy. We're building processes, good documentation, packets to give them, etc., for them to really have their patients that meet swing bed criteria to have them referred over to us and then us accept them. So that's really the next phase of that. The next thing is really accounts receivable. And so it's our AR days. And it kind of, again, ties into our revenue. And so when we think about AR days, that's a whole bucket of multiple claims. You know, when we have claims at different stages of being complete, and they are sitting there to be sent to the insurance company. And so right now we are sitting at about 63 days. Best practice is to be less than 50. And so we want to get that as low as we can, because that's kind of like you sitting on your paycheck, right? Instead of getting paid every 2 weeks, you have to wait 3 weeks or 4 weeks, right? It's the same thing with AR. The longer the AR is, the longer it takes for the hospital to actually get reimbursement from the payers, whether it's commercial, Medicare, Medicaid, etc. And so we want to continue to squeeze that down. Another contributing factor to that is us really kind of goes back to charging, orders, H&Ps, etc. We want to make sure our charts are as complete as they can be when we have, a patient discharged. Because if they're not complete and we send them out, we will get denied, and those claims will come back to us unpaid, and they will also go back into that AR bucket. And so we want to make sure we're working very diligently, and it's going to take all of us to do our part in order for us to really significantly increase our clean claim rate. And what that means is that's when the claim is submitted the first time and it goes and we get paid for it. The third thing is our appointments on the clinic side. And so on average, we have probably had about 20% of our appointments that go unfilled. They're just, we don't even get them scheduled. And so when we think about, every clinic visit and the revenue that takes, we're missing in essence, that's a big opportunity for us. We also have no-shows, and those are also issues that we're also working on. Of the ones that actually are scheduled, there's a percentage of patients that don't show up. We're looking at those trends to try to figure out what are the things that we can do something about, right? There will be some things we won't have much control over, but the things that we do have control over, we want to mitigate. And so that is really the third initiative. All three of those are tied into revenue and help us with what we were initially talking about, which is that back to break even. And that's kind of the goal that we've really set for ourselves. So for us, right, we are ready to build. We want to continue to progress. We want to continue to grow. And so part of that is, one, it's for the benefit of our community. But the other thing is, right, we want to be sustainable. We want to be a healthy organization. We want to be a high quality organization, and we need all those things to help us put us in that position. On the community update, we've had some really exciting things related to kind of collaborating with the New Mexico Health Authority. And so we're collaborating with all the hospitals across the state, and really there's going to be a real directed focus group that's going to be focused on kind of going back to the grassroots, because who's going to be on these focus groups are going to be clinical staff from the ED, obviously, behavioral health staff, but physicians, nurses. We're really trying to kind of find out really what are some of the barriers that we're seeing across the state. And some of those are going to be very, very common, but I'm excited because there's a fair amount of going to be focused within the local area, because every area is not the same, right? And so when we think about our behavioral strategies and how we want to continue to grow that to try to meet more and more of that demand, there are going to be some unique things about our service area that we're going to want to make sure that we put into our plan. And so that is going to be a huge benefit for us as we get the results of that task force. So very much looking forward to what's going to be happening with that. Other thing is the operational update. And we have Jerry Clausen, who is our new materials management director. He started on the 23rd of June. And so as we look at all the opportunities, as I had alluded to, that $500,000 of, supplies that became outdated last year in 24, we really need to retool kind of how we manage supplies. We need par levels established. We need to make sure we rotate our inventory, and we need to make sure we have the right inventory at the right time in the right place. So there's going to be a fair amount of work on not only in materials management, but also within all the departments. And so he is definitely going to be engaging him and his team with the leaders that we have in all these areas in order for us to really make some significant improvement in that space. I know, I'm a nurse, and so I remember being a hoarder. Nurses, we can be bad about that, but really the driver to that is that we've had once or twice where we've needed a specific supply, and then we go in there and we don't have it, and then we can't do what we need to do. And so it tends to build those kind of habits. So we understand that we have not had great processes, and that it's going to take some time for us to build trust with our par levels, et cetera. So we know this is not going to be perfect immediately, and it's going to take some time for us to kind of ramp up to where we're kind of fully operational. So initially, I want to go ahead and thank you for your patience and your support, and hope that you engage well with the materials management team. It's going to make all of our lives better in the future. Last one really is talking about successes to date, and I think one of them would be the recruitment aspects. As we think about, we've kind of best of the best rehires in multiple departments, probably over the last few months. We've had a number of people that have wanted to come back to, our organization. That is super exciting. You all should be extremely proud of that, because people have worked here, left thinking it's greener pastures, and then decide that really this is their home, and this is where they want to be, and this is where they feel like they can kind of fulfill their mission or their calling within our healthcare institution. And so that is super, super exciting. We rolled out our weekend flex positions. We're starting with nursing, and it's going to be in the ED and in the med-surg areas, focused on that space first, because that's where our largest amount of agency is. Our goal is to get to zero agency. We do not want to have any travelers, no agency. And so that is a very focused directive that we are really heading towards, measuring that, looking at that every single week. And we feel like that the weekend flex is really a unique opportunity. Nobody's really doing it in our area. And so just to clarify, that is, it's a part-time position with part-time benefits. So you get insurance, PTO, etc. You work 2 12-hour shifts. So you work 24 and you get paid for 36. And so it's full-time pay, working part-time hours. You work 48 weekends out of 52. So you have 4 weekends off a year. You'll have PTO to be able to cover those 4 weekends, but they're going to be set days. We're planning on expanding it if it makes sense. And we have, other departments that are 24/7, 7 days a week, but we really wanted to focus on those 2 areas first, because we're really trying to alleviate the use of agency. Last thing would be the recruitment. And, we've had we've had really good interviews with about 5 different physicians with multiple specialties. And we've got 3 of them are kind of at the contracting process. And so what that means is that we both agree that we want to kind of be partners. And then really the negotiating comes down to us sending them an actual contract and us agreeing on terms, etc. And so sometimes that takes weeks. Sometimes it can be a little longer than that and can be more than a month, just depending on kind of where those individuals are at in their decision process. Sometimes people are interviewing at more than one place. And so there may be a timing issue where they're not finished with their next interview before they're willing to make a decision. And so as we get those things updated and we get, contracts signed, we're going to be sharing that with the larger group. So we'll keep you updated on as we progress forward. So hope this was informative, and thank you for all the great work that you do. And we'll speak to you the next time. Have a good day.